This week on the BackTable podcast.
I'm looking for the IMA. If I see any kind of blush around the IMA, I know that has to get resolved. And the best way to embolize the IMA is to be in the IMA, rather than being in the sac and trying to find the IMA. So a lot of time, the first procedure I'll do is a transarterial from radial or femoral access, get into the middle colic and marginal artery and get to the IMA. And even if I can't get into the sac where I would need to be, I'll embolize the IMA and take that out. And then if I haven't given the patient a lot of radiation doing that, maybe I'll, if they're already supine, get venous access and try to do a Transcaval and complete the case, or just bring them back, at a different visit and, kind of address the rest of the endoleak that didn't get fixed transarterially. But I think there is benefit in, definitely definitively embolizing the IMA if you see that could potentially be, contributing to the type 2.
I'm your host, Sabeen, and today we're taking on a topic that can haunt even the cleanest EVAR or TVAR, endoleaks. They're tricky, they're unpredictable, and sometimes they're just plain stubborn and turn a routine follow-up into a complex puzzle. Joining me is Dr. Matthew Givens, an interventional radiologist from the VA in New Orleans. Welcome, Matt.
New Orleans.
I know. I got to put the marbles in my mouth. The New Orleans. That's all I got.
Yeah.
We're gonna unpack all these nuances of endoleak. We're gonna do the diagnosis, decision making, and really, I want to focus on how you treat your endoleaks and what we can learn from each other and teach our listeners. And so I'm trying something new these days on the podcast that I'm hosting. I like to ask a provocative question, but we'll answer it at the end of the podcast.
All right.
So my provocative question for you, but it's not that provocative, is what is the single most useful tool you have for endoleak management? And so just think about it in your back of your head. You don't have to answer it now.
Already know.
Well, yeah, perfect. So now, honestly, I want to get to know more about you. I want the listeners to know about you. So tell us about yourself.
Yeah, sure. Well, first of all, thanks for having me on. Like we talked about a little bit earlier, I've been bothering Chris jokingly to get on the podcast because I see him. He also works in New Orleans, a lot. Just kind of like he called my bluff. So,
yeah.
But no, I look forward to talking about this topic. I enjoy it. I think it's a very important topic. But as far as me, I did my med school here at LSU in New Orleans, went back in the military, did my residency there up in Washington State, which is actually kind of where I got into a lot of endovascular stuff. I ended up working with a lot of military guys like Ben Starnes, who you also had on a podcast I saw, talking about EVAR. He's now, I guess, chief of vascular up at the University of Washington. And then from there, did my fellowship at Hopkins, and then came back down and basically been in solo practice my whole career. So from 2010 until current times. Yeah. So you learn a lot working on your own.
So literally just you, what about call? How?
Maybe I've had some help on call every now and then, but yeah, it gets difficult. But yeah, it's been an interesting career. But again, it's kind of good in the fact that when you're solo, you kind of have to learn some, you learn a lot of things the hard way when you don't have a colleague to bounce ideas off of necessarily. So my colleagues, a lot of times, were the vascular surgeons. So, which is kind of where we kind of molded a lot of these, little techniques I use now for EVARs and for endoleaks and stuff.
Totally. I kind of actually want to ask you more about this right now before we get into our topic, but I feel like I learned so much from my people that I worked with, the first couple of years. Like I can't imagine just doing all this stuff, not having that backbone. So did you just, there's solo practice when you started? Did you just become friends with a bunch of different services like the vascular surgeons? How did you do that?
Yeah, you have to have a lot of friends. General surgery, vascular surgery, GI, urology. Maybe a good thing working in a military hospital, everybody's very collegial. It's not a lot of turf wars or anything. And, we kind of had almost a shared practice. I actually had a clinic in the vascular surgery clinic where I do veins mainly, and then, some peripheral vascular work. And, back when I started in 2010, as an attending, there wasn't a lot of people coming out of vascular surgery training that had endovascular experience.
Sure.
They wanted to do everything open. So when, PVARs became a big thing, they kind of came to me looking for a little help on, peripheral. And that was kind of like my way in. So, obviously now it's a lot different. They probably do 80% endovascular work now in their fellowships. And so that was kind of like how I got involved in endovascular work.
Totally. And so in your practice, I'm assuming, being solo IR, you do the breadth of everything then, including, aortic work. You probably do it in. Do you do EVARs with the vascular surgeons?
Not currently.
Or do you do the follow up?
We have a pretty aggressive group here, which I actually appreciate. They kind of tend to do everything. But they're not dumping things on me on the weekend, like cold legs or, dialysis grafts that go down. So, if you're willing to do it all, as long as you're willing to do it on the holidays and weekends too, then, I respect that.
You could just dump it on Chris back when he's working, when he's covering for you. Yeah. You got that, Chris? So, okay. About endoleaks, we've had, an episode or two before about endoleaks.
Yeah, I saw that. I have to follow Sahir Sabri, which was actually a very good 2-part. So when Chris recommended we do it on Endoleaks, I didn't realize that there was already a really good BackTable podcast on Endoleaks.
Well, I think there's been a lot, people do it so differently. That's what kind of I noticed, that there is a lot of different ways to attack it. I do it in a completely different way than some of my colleagues. And so I'm interested to know you. We're not going to talk about type 1s and type 3s, obviously extension of the graft or all sorts of things to fix those. It's really, we're going to be talking about type 2 endoleaks. And just for our listeners that most probably are aware, but what is a type 2 endoleak and how are you generally diagnosing it?
So a type 2 is an endoleak that is usually coming from a side vessel into the excluded aneurysm sac. Normally IMA, lumbar arteries, sometimes median sacral artery. Basically blood that's backfilling into a vessel. Could even be hypogastric artery if you had to stent across the internal iliac. You can get a type 2 there. The way we normally diagnose them is on a follow-up CTA. And, we're kind of looking mainly for sac enlargement. You're looking for any kind of endoleak, type 1As, Bs, type 3s, which are becoming actually more common now with the fenestrated endografts. We're starting to see a lot of type 3s where the renal and mesenteric stents go into the graft. But, most commonly, I believe, it's like type 2s, I guess 25% now. And like I said, you kind of looking for not just the endoleak itself, but for sac enlargement. Would make us suspicious for a significant amount of increased arterial pressure in the sac that might, lead to rupture.
So about that, one is for CTAs, you're saying you're getting those. Is all of the EVARs getting a CTA as a follow-up to your knowledge? Is that what is the vascular surgeons in your hospital, is that a standard follow-up?
Our current practice is a 3-phase CT angiogram.
Okay. Yeah, so you have an arterial, venous, and even
a
delayed one
arterial, 5-minute delayed phase.
Okay.
Which is actually, I don't know how y'all do it, but that seems to be to be the most helpful sequence, just for really seeing the extent of the endoleak.
Yeah, because on that delayed one, you see all that patchy stuff, and you're oh shit, it's actually there's a lot going on in this sac.
Yeah, they're not as impressive on arterial phase, and then you wait a little bit, and you see the real extent of them.
Yeah, totally. And then my other question is the sac enlargement. Is that what's your criteria on timing and sac enlargement and the diagnosis on CTA to take someone for treatment? Is it a specific amount of the sac enlarging? Is it the degree, the endoleak that you see? What are some of those characteristics?
I think for us, the textbook answer, I guess, would be 5 millimeters in 6 months or something like that. But essentially anything that makes us nervous, not just even sac enlargement, but any kind of morphology of the sac. Sometimes you get these little saccular pouches that look like they could be a concern for rupture. Anything is makes us concerned. It's basically, there's a lot of endoleaks you can watch, and the ones that aren't really going to be a problem. They're very confined, and your aneurysm sac is usually shrinking or, stable. And again, normally those we don't do any kind of intervention on. I mean, I can't make him better than,
that, right?
So, yeah, the risk isn't worth the benefit. Yeah, so I guess, any kind of like sac enlargement, for me, main thing about vascular surgery colleagues are concerned about.
Okay. I guess I've been asked this question and I wanted to look it up. I don't know if you know, but have you ever seen a type 2 endoleak rupture?
I did once, anecdotally, but I actually was on call for a locums job. I was working in Savannah. So that's how sketchy this, but just kind of like, it wasn't even at my own practice. And I got called from this little podunk hospital. I was covering the trauma center memorial, and I got called from another hospital where we covered 3 hospitals at the time. And it was aneurysm with type 2 that had ruptured, and the vascular surgeon was calling me like, what do we do? He's got an endograft, so.
What did you do?
I believe I think I ended up going perigraft and got into the nidus and just put a bunch of coils and glue, and it did stabilize it.
Love it. Love it. Okay, good. We're definitely going to be talking about that technique. So, okay. So basically I would say in summary, treatment to people whose aortic sac enlarges, if you want to put a number to it, 5 millimeters in 6 months, but really any enlargement kind of thing. I think that's what we do too. That's my kind of agreement. If I see an endoleak and there's an enlargement, in 3 or 6 months, then treat it. One other debatable question is, should patients with EVARs get a CTA for life? Should they be getting it? If say the there's no endoleak on, year 2 of follow-up imaging, are you done? Or should they be getting a CTA every year or shorter interval?
I'm a fan of the annual, just kind of like more for maintenance and just kind of just looking at your endograft. I guess it depends on what the aorta look like when they first place the endograft. I mean, there's, there's patients you are concerned about. Is this graft going to migrate? Will there be component separation? Things like that. So it's, case by case basis, I guess. But I don't have a problem with a patient getting every 6 months, every year. It's not that much radiation in the grand scheme of things. I mean, I think we do maybe focus a little too much. I mean, I'd make it controversial, but
I think it makes sense. Yeah, just do it.
Well, I would be concerned about if I had a AAA that was at risk of rupture to the point where they wanted to do an endograft in me, I would be concerned about how that looked. And I think I would be okay with annual, just like a little surveillance CT. Maybe even a non-con, just to look at the size of the sac.
And make sure it doesn't migrate. I mean, I think it's so high yield, a CTA, you get so much information.
Right.
And we've all seen it, right? Where the proximal neck degenerates and it migrates like 10 years down the road, right?
Yeah.
And so I think you should get a CTA for life. I think as you know, right, as radiologists, there's not that much radiation on a CT. Like, just do it. I mean, we have these patients right in the hospital that have had 100 CTs and whatnot, right? Any other, people, I don't really like ultrasounds for follow-up. Some people do that.
It's so operator dependent. I think it gives you zero information. It's like, even if you see some flow in the sac, you don't know if it's a 1A, 1B, 2.
Or the operator just pushing hard.
Yeah. Or it's an artifact, or the patient's just, most of the time the patient is just obese and the image quality is terrible, or they just have a bunch of bowel gas. It's just not a very reliable.
I think it's pointless.
modality.
I think it's like unneeded exam. What about, some people like to talk about MRA and like twist sequences. We don't do any of those. Do you do that? And do you find utility in that?
We don't, unless the patient had some like severe contrast allergy. That would be the only time I'll really go to MRI, because again, it's just so much more involved just getting the patients in. But, you get a lot of metallic susceptibility artifact if they've been coiled. I think it's hard to see things. But we do have an abbreviated MRI protocol here for some vascular stuff. I know we use it for a lot for livers for HCC. And so I'd kind of looked into maybe applying that to certain patients that can't get CT, but we don't really have a protocol for it yet. This is kind of something we're talking about.
Yeah, we haven't. I actually haven't seen how the image quality is for EVAR follow-up for MRA, but it'd be interesting. But I know some talk about it and say it's really nice. So it's something worth checking out. Okay. Finally, on as far as like imaging diagnosis, are you trying to figure out inflow outflow of these endoleaks at all on your non-invasive imaging? And does it matter?
Not really. I mean, when I get a CTA for operative planning, like when I see I have an endoleak, I kind of have like a system that I go through. I mean, essentially, I guess the modern thinking is that they are basically arteriovenous malformations, and the goal is always to get the nidus, but you also have to, if you can pick off the inflow and outflow vessels, that's usually the goal. So just like I guess you and Sierra talked about in the other podcast, is just kind of going through an algorithm of, okay, what do I do first? Do I do the transarterial and try to get the inflow vessels and maybe part of the nidus, and then do a translumbar and try to get the rest of it? And kind of like, how do I plan this out? And I'm kind of a big fan of that. Just kind of, I know that the goal is to kind of like pick off the main vessel and then try to get to that nidus. Like I say, if I can't successfully manage that through the IMA, then I'll, use a different modality. I could bring him back, a different visit, and then try to get more into this, the nidus, and maybe through Transcaval or, Translumbar.
Okay. So let's talk about the technique. So you bring a patient in, are you doing these under conscious sedation or GA?
It depends on which procedure I'm doing. Anything where they're supine and I'm not using cone beam CT, I'm fine with just doing moderate sedation. I just did one today. I did a transarterial, and the patient did great with Versed, fentanyl, and a little bit of Benadryl, kind of make him sleepy.
Okay.
For like, 1 hour procedure, 1.5, and he did fine. So anything that they're prone, and I know they're going to be kind of moving around and uncomfortable, or if I need them to hold still because I'm doing something with cone beam CT and the guidance software, then it's much better to have them completely out so you don't have any motion. So you always scan them once.
But your go-to, it sounds like, is you have an endoleak, you're going to go and do a transarterial angio at first. And are you going through the arc at that time?
So kind of like my protocol, and it's not the same for everybody, but it seems like the majority of the time I'm looking for the IMA. If I see any kind of blush around the IMA, I know that has to get resolved. And the best way to embolize the IMA is to be in the IMA, rather than being in the sac and trying to find the IMA. So a lot of time, the first procedure I'll do is a transarterial from radial or femoral access, get into the, the middle colic and marginal artery and get to the IMA. And even if I can't get into the sac where I would need to be, I'll embolize the IMA and take that out. And then if I haven't given the patient a lot of radiation doing that, maybe I'll, if they're already supine, get venous access and try to do a transcaval and complete the case, or just bring them back, at a different visit and, kind of address the rest of the endoleak that didn't get fixed transarterially. But I think there is benefit in, definitely definitively embolizing the IMA if you see that could potentially be, contributing to the type 2.
Okay, so say you're going through, you mentioned radial. Do you have any length issues with radial and going through that whole arc? I haven't tried it.
I've only done 1 or 2. It was always in a patient that had like, some kind of like fem or, and with a 150, you can get there.
Okay.
You just, but you're pushing it.
Yeah.
It's always kind of like you're nervous. when you start coming up the edge of your microcatheter, you did all this work and you're like, I'm almost there.
Like just get a little bit,
just a little bit more, just get past the superior rectal and I'll drop a coil and I'll be done. So,
but you go most of the time groin, and
I
what's
see
your
it
system?
90% of the time.
What's your generalized system like that you like to do? Do you do like an Ansel sheath into the SMA?
Yeah, so
do you just go 5 French catheter? Like, what are you doing?
Yeah, the one I did today, like a 5 French, 45 centimeter sheath or 6 French sheath. Sometimes it depends on what the angle of the SMA is. A lot of times I like a Mickelson. And I like to get the sheath, and Ansel's nice because you can actually get the sheath into the origin of the SMA, which I think is very helpful. Like everything I'll do for these is usually I try to do a triaxial system if I can. So a lot of times what I'll do is I'll cannulate the SMA with like a MIC, get a glide wire down, maybe in a lateral projection, and then come back with a comfy catheter. I'll actually go down the SMA a little bit further, give me more support, and then get my sheath just into the origin, the SMA, to really give myself some support. And from there, try to get a microcatheter into the middle colic. And if you can, sometimes if you have like a 4 or 5 French glide catheter, you can actually get that base catheter around into the marginal artery as well. And those are the best ones. So you have a lot of pushability because it depends on how tortuous that vessel is. The one we had today had these 2 big loops in it, which was really a pain. But having that base catheter in the origin of the middle colic really helped as far as, my system doesn't get completely kicked out of the SMA, because as we all know, there's nothing more infuriating than being almost all the way to your target vessel.
And then boom.
And then your sheath flies up in the aorta and everything comes out and just starting from scratch.
Yeah, I think having the sheath into the SMA and having your 035 system into at least the proximal, middle really helps. I found that really helpful. And then you can get really good injections too, right? Before you do otherwise then your injections are so, diluted or not as much pressure. So then I know we're getting granular, but I wanted to get pretty granular on this technique. Is then do you take your microcatheter into the sac through the IMA, and then do you do a saccogram or whatever you want to call it? Do you do that?
I try to get into the nidus if I can. And usually with the transarterial, you're kind of running out of microcatheter by the time you get into the aneurysm sac.
Sure. Yeah.
So it's also very important that, your sheath length and your base catheter, like your 4 or 5 French catheter length, are not like 100 centimeter.
Totally.
Because you're going to run out of microcatheter. Yeah.
Good tip.
Again, something I've learned from
a hard
experience.
Yeah. Yep.
So, 45 French sheath, 65 French, like a 4 French compy or, some kind of like angle catheter. And then my 150 microcatheter, make sure I definitely have enough length. And with that combination, I rarely had a problem. But yeah, I mean, like my goal is always to get into the sac.
Okay.
And because again, I treat them like an AVM. You want to take out the nidus plus the inflow vessel. I think that's where we get the best results.
Okay. So you say you get into the nidus, you do your angio, and now you see the nidus light up. You see a couple flashes of a couple lumbars flash, and then and you do. So what's your next step?
If I just see a little bit of reflux into the lumbars, then at that point I'm not super concerned about it. If I've done a couple of cases where I've been in the sac and I injected not even very hard, and I saw like lumbars, iliolumbar, internal iliac, and then you kind of, it's a little bit more concerning. And then you're thinking, well, maybe I got to come back and get it from the back door, get into the iliolumbars and up and try to coil these. But that's rare. I think a lot of times you're in there and you maybe just see a little bit of reflux in the lumbars, and then normally what I'll do at that point is, I'm not sure what you tend to use for embolics. I kind of use a combination of coils and liquid embolic.
Okay.
I know you had mentioned you like Onyx.
Yeah, at that time. And then, I've Onyx, Lava. I've tried, the other, various newer agents too, Obsidio and then some glue. So I wanted to pick your brain on your embolic.
Well,
so scaffold with coils and then do what?
Yeah,
liquid?
so I'm a big fan of these framing coils. I know Penumbra has a really good soft platinum coil that's very easy to get through a microcatheter. And because again, we're not looking for like helical coils. It's a potential space. It's a big blob. It's basically a big cavity. And we're just trying to fill it with something that's going to take up space in that cavity. So these framing coils work really well. And it's also, you're pushing through so much microcatheter with these 150s, and then you're pushing into thrombus. So you also have to be concerned about, I've had issues with coils that I didn't like how they were deploying. I tried to remove them, like detachable coils.
And it breaks.
You got to remember that you're not in a vessel with an intima. You're in a bunch of clot. And these, retrievable coils or, these detachable coils that are supposed to be retrievable tend to get stuck in this stuff. And they're not detachable anymore. So I kind of tend to not use a lot of hydrogel coils just because they're kind of sticky. I like just the real soft. I just want a coil that's going to take up space. I want it's going to form like a big nest, and not so much for the thrombogenic effect, but to control the rate of my liquid embolic. That tends to, because everybody gets kind of like nervous. But if you ever use TrueFill, N-butyl cyanoacrylate, it can get away from you if it's not viscous enough. But it's also good for these endoleaks because you want it to kind of flow. You don't want it to sit at the tip of your microcatheter. If you have a big space to fill, you want this to fill the space. But I think the coils just give you that extra control. They tend to kind of slow it down. It's not just reflux into your IMA. It's not going in all these lumbars. You can kind of see it, and you have to be able to see it too. That's another thing. I do mix a lot of tantalum powder into my TrueFill.
So you do coil, your liquid of choice is glue.
Yeah, I think it just,
Okay.
I think
great,
it flows
yeah.
a little bit better than the Honix.
Do you use a standard dilution, Lipiodol in
Usually
there?
3-to-1.
3-to-1, and you use the whole, do you put like half of that tantalum thing in there, or how much do you
about
do?
half of it. It usually gives me just
Okay.
like, I could just kind of barely see it on fluoro. But that's kind of like my sweet spot. I think 3-to-1. It's not super viscous, but it's still, you can see it. It's almost like you're doing thrombin into a pseudoaneurysm. You can kind of see it start swirling off the tip of your microcatheter. And it's like going distal into the sac, but it's controlled, especially if you have coils in there.
I
So
got it.
kind of like just, after doing a lot of these, that's the technique we kind of gravitated towards. I think it gives us the best control with the most distal embolization.
Now, you kind of mentioned letting it flow. Like, don't you want it to flow into the lumbar? If it goes in the lumbar, isn't that a good thing?
Yeah. I mean, I want it to go a little bit, right? But
like,
I don't.
is there too much? Is there really too much to go in the lumbar? Like, what are the risks if, say, you get in lumbar, like, hell yeah, like, let me take this vessel out, this guy.
Right. I guess I'd be more concerned about reflux into the inferior mesenteric. But yeah, I mean, you don't want it to go like down in the iliolumbars and then out. Like I said, there's been a couple cases where I've actually had significant reflux, like almost all the way into the internal iliac.
Yeah. Okay. That's pretty impressive that it's gone that far. Yeah.
But you really don't want it going into superior rectal and then out your marginal artery. So
yeah. That's your biggest thing. Are you embolizing your liquid in the lateral view or partial lateral, or because how are you really looking at the IMA during this time?
You kind of want to get it off the spine if you can. So maybe a little LAO, RAO, sometimes lateral, depending on the body habit. Sometimes lateral is difficult if you can't get the arms out of the way. Yeah, again, it's kind of like a patient by patient thing, but I think most of them we do AP and we can see it pretty well.
And, what's your endpoint? So you're doing the glue, you have let's say about 4 cc's of liquid because of your 1 to 3 dilution. Are you generally using all 4 cc's, or, I mean, it's probably Endoleak dependent?
I will try to get all the liquid embolic in if I can, as long as I'm not seeing anything scary like reflux.
Okay.
And then again, you do a sacrogram and you kind of like, you can really see. And sometimes you just take your microcatheter out and like, you don't see any more back bleeding. That's kind of like a good indication that you've really reduced that arterial pressure in the sac.
Have you ever measured the pressures, by the way? I was once. Yeah, just it's like you're like
you just kind of like when it's really coming out of there, it's
So okay, so you do glue, so you have to bail on that microcatheter, right? So
that is
so you're bailing on your tortuous axis, like you had the 2 loops. So then do you go back with another microcatheter and then coil or IMA after your glue?
Yeah, which is annoying, but yeah, it's kind of like what you have to do. And again, a lot of times if I can't get into that nidus, if I don't really have a good cavity, a lot of times I won't use liquid embolic. If I think I can just throw some big 30 centimeter framing coils in there, and that's going to really, basically, I just need something to fill that space, because if I know the IMA is the source of the endoleak, just filling that potential space of those coils and then taking out the IMA is going to thrombose.
Okay. You're not worried about like another endoleak forming from the lumbars, like a new one after, like how often have you seen that happen?
Rarely. So yeah, I mean, normally, like, if you have a good CTA and the IMA is the source, then I'll just get in there and, put some framing coils in the sac and then kind of like take out the IMA without having to, go through the rigmarole of sacrificing my catheter, there's other techniques that we do that are actually beneficial for that reason, that you don't have to, or you can. It's very easy to sacrifice your microcatheter because you have your 4 or 5 French catheter in the sac as well.
Yeah. So you
But
just pull it out.
so sometimes like I'll use one of those, I'll go like, transcaval or perigraph technique.
So yeah, so about those. So okay, so that's your first. You do. I mean, it sounds like that's kind of your go-to Transarterial, and I think a lot of us do that too. I agree. I have a very similar thought about that's the easy thing to do first. Go in the IMA, take it out. Now, what do you usually just finish there and then see how things go, or how often now are you going? Adding an adjunctive technique such as transcaval or perigraph, and how often, something that we haven't talked about yet is the direct lumbar puncture and your needle guidance. When are you going to those techniques?
If I think I got the majority of the sac through that transarterial, then I'll just quit there, bring them back in a month, get another CTA, and just see how everything looks.
And with all those coils, doesn't that does it kind of streak you out a little bit?
A little bit, but again, if it's a significant endoleak, you're still going to see, especially on the delayed imaging, it's kind of, I've always been able to kind of like tell that, okay, there's still abnormal enhancement in the sac. It's for the most part, I guess it's pretty evident. I don't know. Maybe it can be difficult though. I mean, the coils don't help. Maybe in the glue, when you have all that tantalum powder, it also, it streaks out really bad. Yeah. So I guess a good thing about Obsidia or Onyx, I'm not sure if that happens with I don't think you get the same artifact.
You can see more, but sometimes oblivious is better.
It's true.
Yeah. But okay. So say, you still have an endoleak, then you bring the patient back and you just, does it determine, do you go, what's your next step?
Okay. So say we've done the transarterial, we've taken out the IMA and we were pretty satisfied. We're bringing the patient back in a month and still has a huge type 2. At that point, I'm kind of thinking, unless I see a huge iliolumbar that I could do another transarterial kind of through the back door, I'm thinking direct sac puncture. And kind of my go-to for direct sac puncture lately has been transcaval, kind of for several reasons. I like the patient being supine, and I like being able to have arterial access as well as venous access. So when we're supine, I can actually get access into the artery, go up, shoot in the aortogram, and definitely confirm that there's no type 1A or B. And then have the venous access where I can actually repair the endoleak. So, it's just easier. You actually have, I think, more positive control when you go transcaval versus translumbar. But like our technique for transcaval, like I said, we'll get access usually, femoral vein. And I kind of I'll use cone beam CT just kind of like for targeting, just to kind of really see where the biggest component of that endoleak is. And, sometimes that's why it's good to have the arterial access. I can do an angiogram, then spin them. And sometimes you can see where the biggest component of that sac is for targeting. We like to use a Rashashita set. I think it's just, it punctures through the sac a lot easier. I actually had certain aneurysms that was very, very difficult to punch through that arterial wall. I don't know if they've had an infection or some kind of, I don't know what, scarring, but there's been times where the needle from the Rashashita actually deflects, almost like you're trying to go through a cirrhotic liver. So sometimes in that it can be very difficult to punch through that sac. But most of the time it goes through really easy. But kind of AP lateral images to make sure I'm nowhere near the graft itself.
Yeah,
and
you don't want to puncture that. Yeah.
And a lot of times your tip's set up, you shoot a quick venogram, and you actually see where the aortic aneurysm is pushing in on the IVC. And so it kind of helps with targeting as well. And a lot of times too, you there's calcification in the arterial wall, so you can see it on fluoro. So, the targeting is actually relatively easy. So you punch through with the needle and then kind of get the catheter that comes with the Roche set into the sac, get a wire up, like an 035, maybe like a glide, a stiff glide. And then, usually I use like a 4 French glide catheter through that. And, from there, you can work through that 4 French catheter. I tend to use, especially if I'm going to use liquid embolic, I'll put a microcatheter through that. So that way, if I use glue, then I can sacrifice that microcatheter. I still have access into the sac, with the 4 French.
You have the catheter to the Rosashita, the outer sheath.
Right.
And then the 4 French catheter, and then a triaxial.
So the metal stiffener in a Roche does not go into the aneurysm. So it's in the cava still up against the arterial wall. The only thing that's actually in the sac is the catheter. Is it a 21 French, I believe, or something like that. So you punch through with the needle, get your like a V18 wire and get that catheter in, and then you switch over to a 3.5. And that seems to work really well. You have a lot of pushability because you have that metal stiffener kind of in the cava pushing up against the aorta, so it keeps your system from getting kicked out if you're deploying coils. And you have a lot more control. So you can get that 4 French or 5 French catheter all around the sac. You can get it where it needs to be. Or if you just take a microcatheter with like a transcend wire or something like that, normally you can get into all the different components of the aneurysm or the endoleak. Because a lot of times these endoleaks aren't like a simple blob off the end of the IMA. It's like a bunch of different little, individual sacs and they don't necessarily all communicate well. So sometimes it can be kind of difficult trying to, find all of them. So having that control, having, like a triaxial system like that, I think just helps significantly when you're trying to navigate inside this. Basically, it's like a bag of clot. I think a lot more control versus translumbar.
Okay. Yeah. Because also your angle, right? Your angle is
Yeah.
way more, you're not fighting a 180-degree turn if you need to go to some things.
That's true.
And are you ever worried? So now your IMA is protected because I'm presuming it's already coiled.
Sure.
Do you just slam liquid embolic then and just see where it goes?
Yeah, we do a little blobogram. Make sure nothing looks suspicious. Nothing. There's no type 1 component that we didn't catch initially. Because I've had a couple where I'm inside the sac and I inject and I see it coming out like around the top of the graft, and that's always
You're like, okay, yeah.
And it's like
that's all
maybe
scary.
we use coils on this one.
Yeah.
But,
okay. Then, but
so
otherwise,
there's a lot of information you can get from that your
Blobogram.
your angiogram inside the endoleak.
Yep.
But
Are you
normally
ever
at that
worried
point, I'd be a little
about-
more. I'd be kind of cavalier about liquid embolic and coils and
I
stuff.
figure.
Yeah.
You ever worry about like that embolic, your catheters getting stuck in there?
No, I've never really had that happen. I could see how it could happen, but not to the point where I'd be concerned about or thinking I have to use one of those breakaway catheters or anything like that. I've never really had an issue with it because you're not really leaving it in. Like I kind of like inject it, I'm taking it out. I'm not doing more work through that catheter. Once you inject true fill, it's done. Yeah. So you just kind of remove it. But the good thing is if you're Transcaval, you still have your 4 French catheter in there, so you haven't really lost anything. You put another O1, you put your O1A wire back out, put a new microcatheter in, and keep working if you need to.
Mm-hmm. And okay, and so that's great. I personally haven't tried the Transcaval. What you mentioned perigraft? Have you done it? I'm a big fan. So
the first one I did was by accident, and I loved it. I was literally with a friend of mine, one of the vascular surgeons. We're kind of doing his endoleak, and I was just going up with a glide wire, and it just got behind the graft. I was like, oh, okay.
Yeah.
So I got a 4 French catheter up from there, and I was like, this saved us so much time.
Yeah.
It was so.
That's nice. What are you thinking?
I tend to do you normally put a sheath up behind the graft? I mean, people have told me like, oh, you got to give it a type 1B.
I haven't seen it happen.
No, I think those grafts are pretty robust.
Yeah. I put a sheath. I put a 6 French actually into the sac.
Right.
And then it's basically like your Transcaval, right? You have all this maneuverability.
I've actually gone up with, but at first I was kind of nervous about it because I had somebody kind of like tell me that I would use like a slender sheath. I was like, well, I'll do a sheath, but I'll use like the smallest caliber.
That 1 French is gonna.
I'll get that up and then get the catheter through there. And then after that, I become a lot more cavalier about it. I've never seen one. I mean, if you did see one at the end, I think you could just put a balloon up and that would fix it.
I mean, we've done, I would say perigraft, we've done over like probably more than 30, 40 of them. And we haven't seen type 1B occur.
But again, I like it. It gives you all the benefits. So like we were saying, you don't have that 90-degree turn with a hacky stick set, and you have zero control over your wire. Just kind of like you're just hoping it'll get there. And with all the real estate you have to navigate around, like kidneys and bowel. So I think it's right there, and it's direct. You you have all the pushability in the world to get your coils in. It just makes sense. So I don't necessarily try that one first, but I'm always thinking about it. Sometimes, again, if I'm, trying to do a transarterial and I have a wire
You're
just
already
get
there.
behind the graft, I would probably take it.
Yeah. I agree. So, I mean, at least for me and something that I try to advocate for, and people who've tried it, they like now is like, yeah, I like the transarterial, I like going through the arc, embo that IMA, and then I just go in trans perigraft. You're already there. And it's pretty easy. You just take a compy and shove a stiff glide on the lip of the graft and it goes
Right.
up.
And then you can do like 035 wires through that, or coils rather.
Exactly.
See, now you got me wondering if I don't just do a lot of these transarterials just because they're kind of fun and we like the challenge of.
It is. It's like
You know.
you feel good. You're like, oh, look at all this transarterial stuff.
Right.
It's
But I
look
really
at all
do
these
think
loops.
you have to get that IMA. I mean, if you definitely see it's a component of it, and the best way to do that is be in the IMA.
And it's nice because you want to embolize it. Then you don't have to worry about liquid. If you go transcaval,
Right.
perilumbar, or perigraft, then you can be cavalier, right? Otherwise, I'd be scared as hell that
Because
something's gonna freaking fly.
if you've ever had non-target embolization into the marginal artery, not good. Yeah, I've had
No.
So
That's a problem. Yeah.
yeah,
And so you mentioned needle guidance too. So are you doing sometimes some direct access and doing needle guidance? I haven't.
mainly if it was translumbar. I like beam CT. And again, it's like everything depends on which way the sac's laying. If it's away from the cava, you can't really do transcaval. Sometimes you just have like an aneurysm that just kind of like it lays over to the left side too much, and you just don't have that window. And then you kind of have to do, direct sac puncture. If I'm going to
There's
do
always
that,
perigraft. There's always
yeah, well,
perigraft.
yeah, exactly. I hate when the patients have to go prone because if I do have to
Yeah,
do an
sucks.
aortogram, then what do? Do you flip them over, get femoral access, shoot that, then flip them back? And if they already got like a needle in their back, it's just so
It's
awkward.
painful.
And then now you
Yeah.
get this patient that might be obese and they're face down and they're not satting well, and your nurses are nervous. And I just think there's a lot of benefit to keeping them supine. I know if you have to use anesthesia, the anesthesiologist will love you if you can keep them on their back and you don't
Yeah.
have to go face
Yeah.
down,
Or if
with
you,
a
yeah.
endotracheal tube.
Totally.
But if I did have to target a particular area in the aneurysm sac, I'm a big fan of cone beam CT. I mean, we have Philips, so the proprietary software for that is a expert guide. That's what I use. I'm not sure what it is on. Siemens has some others don't know what it's called. But I mean, it's kind of like a cheat code. You do a CT scan, you spin them. A lot of times I'll do an aortogram, and then you kind of like you spin them, you see where the contrast is, and just kind of like draw your little line. And you go in there, and it puts a little virtual, kind of like a tunnel on the screen. You put your needle right down, and you're, 9 times out of 10, as long as the patient doesn't move on the table or something. So
If you're doing cone beam and you're doing aortogram, how much contrast? Like, what's your settings? Like, are you doing a lot of contrast and the delay? Like, how much is that
no,
requiring?
not really. It's kind of like we just wing it. Like
Yeah.
I think it's not necessarily a delay. Like if I'm gonna do it, because they're gonna be supine. Usually when I inject them, and then we'll flip them. And by the time we do all that, and then it's kind of like it's like a 5-minute delay. You're kind of getting it. But I mean, I do so few translumbars. I would have to refine my technique if I ever did another one.
Yeah, it's been a while for us too. I mean, like I said, our go-to is transarterial and perigraft. I mean, and with all those two, it's worked out well. Now, we went really hard on the technique, and I'm glad because I think that's what I mean. There's so many ways to do it. When do you stop embolizing? So, okay, say I've had these cases where, okay, you got the nidus, you got the IMA, and now you can't see crap on your CTA because there's so much streak everywhere,
Yeah.
but the sac is enlarging. What do you do?
Oh, I think
First of all,
that
am I the only one who's had those cases? Because I have
no,
had like
man.
2 or 3.
Yeah.
They come, right? So
Yeah,
what
absolutely.
do you do in those, and what are the options? When do you go? When do you pick up the phone to your surgeon and say, okay?
And again, the surgeons are always I've made this phone call a couple of times, and it's always kind of like humbling, especially if you've done 2. So you've done the transarterial, take out the IMA, and then you've done the transcaval, and the guy's still got an endoleak. and you got to call this vascular surgeon that you're trying to get referrals from and be like, yeah. and their response is usually like, well, what do you want us to do? I mean, they're not going to take them to the OR. They don't want to. That would be like worst case scenario. I think that point you have to get in there and do another angiogram. And I think the best way, like you said, would be, another Transcaval, or just perigraph. But you kind of have to, you need real time imaging to see where stuff you might not get on the CTA, where you inject in the sac and you're looking for lumbars. You're looking for maybe like a type 1A or B that you didn't catch initially. And I think really the gold standard rather for seeing that is just on the table angio. Just in there with a 4 or 5 French catheter doing a hand run.
Doing like GA, doing breath hold, like getting everything.
Right. Yeah, but getting like good quality images. Yeah. And I think 90% of the time you can diagnose it from that. If the sac's enlarging, there's a significant problem. And a lot of times if you've taken out everything, it is a small 1A or B that you didn't see initially. So I think, but after you've embolized everything else and you get in and you do an angiogram and whatever nidus is left, I think a lot of times you end up diagnosing it. I've seen that a couple times where I saw like on my initial scan or when I first did the 2 endoleak repairs and it looked like everything was good. And now I bring them back and squirt them again. I've had this happen to me a couple times. And, when perigraph injected, and I actually saw contrast going down around the contralateral limb in the iliac artery. Okay. And I was like, well, there's the problem.
Be a type 1B.
Yeah, it totally wasn't even evident before, but it presented because we embolized everything else, and now you can kind of see, it's another issue.
Yeah, interesting. And then for those, they just embo the hypo and extend the iliac.
Right. I mean, and that just goes back to vascular surgery, but at least now they have that's something they can do if they got to extend it down and, across the hypogastric or whatever. But yeah, I mean, at least then we know for sure that's the problem.
What is like your worst complication that you've seen from an endoleak treatment?
I lost a coil into the marginal artery. It was super infuriating. Yeah. Last coil of the case, doing an IMA.
Shoot.
And it just, I can't remember. Like, I'm not going to say what the vendor is because I still use those coils. I mean, I'd like them. It might have been user error, but the coil didn't want, again, when these coils are in clot, they don't act like when they're in a vessel. It's just, they get super sticky. It's really hard to pull them back inside your microcatheter. So if you don't like it, if it's coming out, if it's deploying too far out of the IMA and you're too close to the superior rectal and you're like, okay, I'm going to just bail on this coil. And now it's stuck. It was stuck inside my microcatheter and it broke off. So no longer detachable. Now it's just a big, long 15 centimeter pushable coil. It's in the micro. So the micro is kind of like still in the IMA, right near the IMA and the junction of the superior rectal. So super sketchy. So I didn't want to blast saline in there because I know it's probably going to just go into the, so I'm like, well, maybe I can just try to scooch my microcatheter back and a coil come with it. It did.
Yeah, that's what I shoot. So it just unsheathed the coil.
It just unsheathed the coil into the marginal artery.
Oh God.
And patient did well. I was like, well, I don't know what to do with this. Maybe just anticoagulate him. And I talked to one of my vascular surgery colleagues. And he's like, you know what? Nah, we're just gonna take him to the OR. Which that's not what I wanted to hear. And they removed it.
And then what do they do?
He did a cut down on the IMA and he pulled that coil out and fixed the endoleak from there.
Wow.
Which is like,
dang.
I was like, dang. So it's good to have skilled colleagues.
That's really cool. I did not know you could do that.
We have their back when they have a complication, but they have ours sometimes too.
Yeah.
We get so used to bailing other people out. Sometimes we forget that we might need some help.
Yeah.
And it was nice to have a guy. And he's like, well, happens. All right, we'll go get it. So
yeah.
And I feel bad about it to this day. But again, it happens.
I mean, that's what I would do too. Maybe try to put some suction on a syringe while trying to take out the microcatheter. But that thing is,
I was trying to put it just, it's a microcatheter. There's only so much suction you can put on that thing. And
then I guess the only other thing you could try to do is put a wire in the microcatheter to kind of try to deploy it, but it probably wasn't.
Well, I tried, even after the coil deployed, I was trying to get in there with like a little pusher wire, trying to push
Get
it.
it
It just
in.
wasn't going. Yeah, it's like
Yeah,
you can't get a snare in the marginal artery. It's just so tiny. That was one of those things. But yeah, you learn from
It's
your
gonna
mistakes.
happen when you do these kind of things.
You're
It's
gonna
gonna
make
work.
mistakes. You just got to learn from.
I mean,
And, but
this is just it happens. I mean, it's a tortuous vessel. These it's tough.
But in the grand scheme of things, I think that's probably the worst. When I did my first Transcaval, super nervous because I'm like, oh my god, I'm just making this big hole, and what if it gets like a aortovenous fistula or something like that?
Fistula.
But that's
Yeah.
just doesn't happen. But I always shoot a venogram afterwards just to make sure I didn't, because I mean it is a very stiff, this tip set you're putting up against the wall of the IVC. You can see it could easily dissect maybe, or yeah, but it's just been. I mean, I've never had an issue. And again, because you think about like how bad we traumatize IVCs when we remove Optese filters. Or,
They can
you know what
go.
I'm saying?
They can go through a lot. Yeah.
Yeah,
It's,
they can kind of take a beating. So I think we tend to forget, these things are pretty robust. But knock on wood, not too many complications.
Yeah, I forgot I was going to ask that. So at the end of the Transcaval, you just take out the system, do a venogram.
Yeah, pull everything out. Yeah, just shoot a run through the tip sheath. And yeah, every time I've done one, there's no extrav, anything like that.
Yeah, awesome. Okay, so I know we got to wrap things up. I'm glad. I wanted to kind of really just delve in your technique. I mean, again, there's so many ways. I strongly suggest people try the perigraft a little
Yes,
bit more.
it's great.
I've had extremely great success with it. It's a nice adjunctive type of procedure. Now, coming back to our question about what's your most important tool that you can't live without for an endoleak treatment, what is it?
Framing coils. I think that kind of
Got it.
changed the whole paradigm. They just fill that potential space so well. I mean, multiple vendors have them. I tend to like really long, just soft platinum coils. But I think just they deploy easy. I've not had a lot of issues with my microcatheters getting kicked out since I've been using those. And just having that framework of coils before you do your liquid embolic is giving me so much more confidence that the liquid embolic's not just going to go somewhere that, I'm kind of like. And because a lot of times too, especially a true fill, it is difficult to see if you don't use enough tantalum. And so you're not 100% sure of where all your liquid embolics going. But having those coils there has really kind of like made it more like doing almost like a thrombin injection where you kind of see the swirling on the ultrasound. I think you tend to see that glue kind of like going around the coils, and it just gives you a better idea, like, how much it's filling that space. So that's kind of been the best thing, and then cone beam for, if I have to do a translumbar, it's also been, keep you out of the kidney and
And then you don't have to wheel the patient from CT to angio, which
right. It's just all right.
Yeah.
Has anybody ever done, like, if you had to do that, that's crazy.
I haven't honestly. I think it's been like 6-7 years since I've had to do a translumbar, and I used needle guidance for hours, but I know that's what people would do. They would do that without the needle guidance software. So
Yeah, you kind of like me. Like your go-tos are transarterial paragraph.
yeah, and
Try
and then
Transcaval. I think you'd like it.
yeah, I'm gonna try the Transcaval. I've always been like, oh, and then I'll just go to my, my comfort zone of perigraph.
Yeah. Oh yeah, it was the first one I did. I was freaking out. I'm like, oh god, this is good. And then it was super easy. It worked very well.
Love it. Well, great. I mean, any kind of imparting words of wisdom to people who
To
are,
the youngins,
to the youngins, to
the
the young
youngins
guns
coming
out
up,
there.
be collegial with your surgeons. They are there to bail you out as well. It needs to be a team. But again, I built this practice basically by reading the CTAs. When the vascular surgeons kind of looked at my dictations and saw that I knew the lingo, I knew what an endoleak was, I knew the vascular anatomy, I knew what kind of graft they deployed, whether it was a Cook or a Gore, whether it was suprarenal, infrarenal fixation. I knew that, things like that. When they see you know what you're talking about, they have a lot more confidence in sending you procedures. If you go to their meetings and you talk to them and they understand that what, not even like endoleaks, like peripheral vascular disease, Rutherford criteria, Wi-Fi. When they see you read the same articles they read and you talk the same language, they're much more friendly. And I think that's kind of like what's helped me out my whole career is just having a lot of vascular surgery colleagues that kind of took me in and, gave me work and, kind of brought me along. So I've gotten to the point now where like my residents that come over from LSU, we have residents rotate over here. We get them timed with the vascular surgeons to just watch them, do dialysis graft work that we don't necessarily get a lot of here. So they get to see that because we're all going to do that in our, in our jobs. So it's definitely had, paid dividends. But again, most of that stuff just came from my diagnostic work. You show them that you know what you're talking about and, they know they can call you on the phone as they can have like a conversation like with one of their colleagues. And it's just a lot easier for them to refer things to you if you have that kind of relationship. It's the same thing with anything. Interventional oncology, TZO-BEV is no, Urides criteria, read liver MRIs, and, you'll kind of you'll build a practice.
Yeah. Know what you're treating. Know all about it.
Exactly. Know it inside and out. Go to the meetings.
Know it inside and out and be the expert, really. Right.
Right. Definitely.
Well, great. Well, Matt, thank you so much. And I know it's getting late over there too. This was, very enlightening. And I think it's important for everyone who's doing these type of cases. It's not like you're getting a high volume.
Right.
It's not like these come, once a week or something. So
right.
It's something you kind of want to know all ways to treat it. And you kind of learn from each one. I'm still learning on them. So that's why it's really good to talk about it and see how people are doing it. Feel free, you have any questions for Matt, myself, anyone else, just shoot us a message on any social or through our website, and we'll be happy to answer them. So
do Endoleaks, they're fun. It sounds complicated sometimes, but it's all catheter wire skills. That's what we do.
Yeah, absolutely. So, well, thanks again, Matt.
All right, thanks.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabeen Dhand,
and Aaron Fritz. Our production team is led by Kieran Gannon, Aaron Bowles,
Gabe DeGrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.